Bismillahirrahmanirrahim. Assalamu alaikum, dear students. I am Professor Dr. Najmullah. They are all final students from FUNC, and today they asked a question: what is internal hernia? So I will briefly discuss with them what is internal hernia. Internal hernia basically means intra-abdominal hernia. And intra-abdominal hernia, this hernia can develop through any potential defect in the abdomen or in the peritoneum. Most common potential defect are fossea or recesses or paradoudenal fossea. These are two in number. One is on the left side. Here I would like to show you on the picture. And left side basically, this is a recess of fossa where inferior mesenteric vein leaves or enter the retroperitoneal space. I can show you. I have in my phone. Focus this. It will be a bit difficult if you can focus this. This is the left paradoudenal fossa. This is the left paradoudenal fossa. Later on you can check it. And this is the right paradoudenal fossa or recess. This is basically a fold which is raised due to passage of inferior mesenteric vein. And this is a right mesenteric fold that is raised due to passage of superior mesenteric artery. So these are basically two potential defects, and internal hernias usually can develop through these potential defects. Most common is the left, and left fossa is also called Landzert fossa. Fossa of Landzert, L-A-N-D-Z-E-R-T, fossa of Landzert. And right fossa is also called fossa of Waldeyer, W-L-D-E-Y-E-R. Fossa of Waldeyer. Now, most common hernia is on the left side. What happens? Small bowel loops, jejunal loops can herniate through this fossa into the left-sided mesocolon. This is common. Right-sided is rare. And another cause of internal hernia is this you can also include in a class of internal hernias. Whenever patient develops some chronic illness like tuberculosis and adhesions are formed, and also post-operatively, patient has undergone laparoscopy, post-operatively adhesions develop. If there is a band between two gut loops, there is a band in between, a small narrow passage or hole is formed due to this. Any loop of gut can herniate into that, opening a hole, causing problem to the patient. You can say a type of intra-abdominal hernia or internal hernia. Now what happens? How the patient will present? Patient will present with the sudden onset of pain, abdomen. Patient may give history of vomiting. Patient might develop constipation, that can be relative constipation or acute constipation. Now hernia may get reduced itself, if it gets irreducible. If it becomes irreducible, patient will also develop signs of obstruction. And if again, if no intervention is done, further complications develop, that gut groove may get gangrenous, and after that it may perforate. So patient might be having signs of obstruction. Then abdomen may be soft, but if it gets strangulated, then patient might develop tenderness, patient may be having tachycardia, patient may have a toxic look, and if it becomes gangrenous and perforation occurs, then patient can come with full-fledged peritonitis. So diagnosis is mostly clinical. When patient report to you, simultaneously you will have to reassure the patient, you will have to resuscitate the patient, and you will take the history. As I told you, vomiting, pain abdomen, constipation, these can be the presenting symptoms. Then on examination, tachycardia, on examination of abdomen, it may be soft. If hernia has worsened, patient might have tenderness, and if perforation occurs, then patient might have signs of peritonitis. How will you investigate? Along with all basic investigations and clinical examination, you can do ultrasound. X-rays are very important. If you do plain abdominal X-ray, direct instrument, you might see the air fluid levels, which are strongly show that patient is having some sort of obstruction. Sometimes if diagnosis echo, you are not sure, you can proceed for CT scan. But one important message is that if you are suspecting internal hernia, early intervention is very important. One important saying is our oldest surgeons, what they have told us, that the sun should not rise and set before you intervene. Any delay will lead to worsening of condition and addition of complications. So very important that you should intervene as early as possible. Solution is the surgery, and you will have to prepare the patient for laparotomy. On laparotomy, important is that first you will explore the whole abdominal cavity, and you will try to find out what the problem is. And if you can find that there is an internal hernia, most important is, along with resuscitation, you will have to correct the electrolyte balance, you will have to correct the hemoglobin of the patient, all necessary things you will have to do for safety of the patient and for betterment of patient. But we are discussing the surgical aspect of patient. First of all, you will have to reduce the hernial sac. You will have to reduce the contents of hernia. Now, 1, 2, 3 things you might see. One is that gut is viable. And what are signs of viability? Gut will be reddish pink. Gut will be having healthy look. You will be able to see the pulsating vessels. Peristaltic activity might be there. Gut will be shiny. And if you try to palpate the gut, you will be able to feel the whole thickness of the gut. And in equivocal cases, when you are not sure whether gut is viable or not, then you can do the color is dusky. It is not red pink. Color is a bit black. Color is dusky. Another extreme is that it is gangrenous, damaged gut. Then again, the scene is not difficult. You will have to resect it, and you will have to restore the continuity of the gut. But if you are not sure whether it is viable or not, Then one thing you can do the Doppler to see the blood flow, Doppler ultrasound. You can use oximeter to check for oxygen saturation, and other thing you can compare the gut. Again, if the thickness is normal, good. If gut has become thin, it has thinned out, then might be damage as paradoudenal. An important thing which we used to do in such cases is that we wrap the loop of gut in a moist, warm towel or pad and tell the anesthetist to give 100% oxygen to the patient and wait for 2 minutes. If color returns, that again becomes reddish and pink, looks shining, pulses return, and you might see the peristaltic activity. That is an indication now you can leave the gut as such. There is no need to resect it. Otherwise, if there is no return of color, there is no change, gut is dusky, not very shining, no peristaltic activity, no active pulsation, then you will have to resect it. And after resection, it is important to restore the continuity. You will have to re-restore the proximal and distal gut loop. And this is was all about a brief discussion. What is internal hernia, which one is the commonest, and how to deal with the patient. Any question? I hope I satisfied you people. You got the answer. What is internal hernia and how to manage, and being surgeon, how to proceed for surgery. And what is viable gut? These are also viable questions. Sometimes you are asked, what is how you can check the viability of gut? What are the signs of viability? And any question, I will be happy to answer. No question? It means either you did not understand anything, or you understood everything. Understood. Thank you very much. Thank you very much.